Thank you, Dr. Asnani. So, I mean, I think one of the things that pleases me most about the conference is actually that our staff have felt empowered to participate. Thank you very much for your comments. So, for the final session, I'm going to introduce to you Mrs. June Harris, who is our head nurse. I came home in 1997, and Nurse Harris was already installed at the sickle cell unit. And her commitment to people with sickle cell disease is unquestioned. And I would just say that whenever a new doctor comes to work at the sickle cell unit, I say to them, no. If Nurse Harris ever says to you, Doc, do you really want to do that? Don't do it. Think about it very carefully, because she's so polite that she's never going to say, why are you doing that? She's just going to say, Doc, do you really want to do that? Take advice, because her expertise about sickle cell is tremendous. She's our leg ulcer guru, among other things. So we're very pleased to have her co-chairing with me this afternoon in this final session where we're going to hear from our patients.
Thank you very much, Professor Knight Madden. This is the final session of a wonderful two-day Sickle Cell in Focus conference. How many of us enjoyed ourselves here? And we certainly cannot end this session by not having a patient's perspective. So we're going to be now looking at research and care from the patient perspective. And I'm going to introduce to you our own Miss Maurette Wright, who is the co-founder of the Sickle Cell Foundation in Jamaica, and she's our first panelist in our panel discussion. Maurette, welcome.
So if I should weigh in, do I need the hematologist or the family practitioner? I need both, but more so the family practitioner. Oh. Yes. So it's an honor to be here. Unfortunately, I was not able to make it for every day. Came in after lunch. I was really empowering to be here. And so I will spend some time with you. In preparing, it was like a lot of information, and I was told it's 20 minutes. Initially, I thought it was a conversation, and then I'm told it's a presentation. So I'll start by sharing, as a teenager, I was told, nobody will employ you because you have sickle cell. However, I was not deterred by that noise. It didn't derail my goals nor my dreams. I completed high school. I went on to Teachers College, completed a first and a second degree. I taught at the secondary level, and yes, part-time at the tertiary level. And I have been employed in HR for a global company and hire people across Jamaica at different levels in the region, and I've even recruited in the US and in Canada. And I say, how God has a sense of humor. But I start with that story because my achievement would not have been possible without the care and research, care of my family and friends, care of medical practitioners, and definitely the advancement in research that has taken place. And so with that, I'm happy to be part of the conversation today. So this chronic genetic disorder is one that has lifelong implications because we carry it from birth until death. And so our life's journey is mixed with physical, social, and emotional pain. And when I reflected, I said, boy, life hard. Life is hard for the sickle cell patient. So I can't just go into care without the context of our reality, the physical challenges that we we experience the extremely painful crisis that affects us. It can range from a day to months, and this affects us anywhere in our body. Those impacted by jaundice. Some patients have had stroke, and we heard about it, and I mean, it has aborted their dreams. Some are affected by sickle retinopathy, and they've lost vision in one or both eyes. Approximately 70% of our adult patients have had the dreaded leg ulcer. Some of us, like myself, have been affected by avascular necrosis of the femur. So we've had persistent hip, knee pains and have limped. And then the psychological issues are many and they vary at school, in the workplace, and even in romantic relationships. So at school, children have to endure teasing or missing exams, being absent for prolonged period, or being told by the teacher, because you have leg ulcer, stay home, and so that aborts the child's education. At work or in the labor market, there are those who dread going for an employment opportunity because some are even screened out of the selection process because of the tests that have to be done. Or being in the workplace, having to endure discrimination and insensitivity because of the air conditioning. You know, the place is cold and it's centralized AC. And how do I, or when do I? So you have to endure that. And for me, what I find to be one of my greatest struggles is on a day when I can't go to work and have to communicate that I'm not well. It's very, very difficult. And it was in more recent times I realized. And so I push it. There are times when, I'm not well, but I push it because I hate to communicate that I am not well. And so I'm not able to make it to school, to work. And there are those of us who have had withdrawal syndromes, as you call it. So there's limited social involvement. Because of the anemia and the lethargy, we're not involved in a lot of social activities. Some people don't have a lot of friends. There are all of these effects that, impact us emotionally, socially, and it leads to depression. It leads to low self-esteem. And it certainly can compromise our life chances. Hence the need for care from a patient perspective. We also experience a lot of misconceptions and discriminations, even among medical professionals. I was said today, so there are those who feel that we're drug addicts because we are reliant on certain strong painkillers or medication based on the severity of the issues. And so, it makes life really, 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 really challenging. And it's a highly variable condition. So there are some patients that will suffer multiple effects. And for some, it might not be as severe, because yes, some will have more frequent painful crises, or some might have, just one episode for the year. So it's highly variable. But what is even more difficult is when you have multiple issues to deal with. What is even more difficult is when you do not have the financial wherewithal to handle your care, when you do not have a supportive family to help you cope. And we believe that, like any other challenges, once you have the support, once you have the care, then you can achieve your goals and you can make meaningful contribution to society. So in addressing the topic of care from a patient perspective, I thought of 3 areas. And I've heard, even while being here, some of the topics and the issues being raised. What I thought of in the Jamaican context is screening and identification, specifically newborn screening, the health system, and support. So those are the perspective from which I looked at care. So in Jamaica, yes, we know we have blazed the trail as it relates to screening and identification, and really want to acknowledge the pioneering work of Dr. and Mrs. Sargent and Miriam Forbes, who are part of the preliminary Jamaican sickle cell cohort study that started in 1973. And that definitely set the stage for a lot of work that has been done. But screening has evolved and it has gone through phases. And you've heard that when the cohort screening ceased in 1981, it was the sickle cell support group that I co-founded. It was our very first public forum. And the permanent secretary, the then permanent secretary, Dr. Carl Blight, he came and he spoke. And we lobbied him to restart the neonatal screening. And that took place, it was 1993. And it restarted in 1995. So we were able to influence and advocate for the restarting of newborn screening. Professor Sargent continued with the Manchester project, and Dr. Knight-Madden, Professor Knight-Madden, continued until today we can say we have for the public health facility universal screening. And that is a significant achievement as it relates to care, because you hear the mantra, early detection saves life. And in the presentation, we talk about with screening, it decreases mortality and it also allows for the education of family members. So screening is critical. We cannot, and you all know that, for the care of sickle cell patient, that's where it starts. But let's go back some 40 years ago. As a young girl living in rural Jamaica, Lacovia, St. Elizabeth to be exact, as a very sickly child. So I was referred to as Eldon's sick daughter. And this was because of the constant pains and the frequent doctor's visit. Nobody knew what was wrong. And so, through the doctor's visits, I was eventually tested and diagnosed with sickle cell disease. This condition was unknown to my family. My mother was also told that no first child has sickle cell disease, much to her distress, as she knows that I am her first child. So clearly, we missed the newborn screening process, and my family missed the counseling and the education like several other patients back then. Fortunately, I was later introduced to the country clinic held at Black River Hospital once per month, and also to Dr. Sargent. So he was very thorough in his data collection. He visited our home and he collected blood from all the family members. And when my father was not at home, Dr. Sargent went to him in his field and got his blood. But that experience marked the evolution of the sickle cell knowledge in my family. So when all my siblings were tested, it turned out that there were 3 AAs, there were 2 AS, and there were 2 S's, the first and the last. But, the story of my family could have changed if we had newborn screening. Not that I wish anybody wasn't born, but 2 of my baby siblings had gastroenteritis. One was 3 and one was 1. One died and the other survived. It turned out the one that survived is AA. And in retrospect, when we looked at our family gene, we felt that that girl who died could have had sickle cell. And when I looked at the research findings from the cohort to say gastroenteritis is there as cause of death, I'm like, whoa. So I could have, in fact, had a sister, because I have 6 brothers and no sister. So newborn screening, as it relates to care, provides the highest level of care for the child, as care commences immediately during that vulnerable period, which is what you all have been talking about. So the family is better able to manage from that vulnerable risk period into adulthood. And also, the early detection provides opportunities for the counseling, for the family, and importantly, provides more information on the disease. Because we often hear ignorance is bliss, but not in the case of sickle cell. An important strategy as it relates to screening, which we have been promoting in Jamaica, is screening for the trait. So we recognize that in our society, 15% of the population has a trait and is at risk of having a child with sickle cell disease. And that's one of the work that we have been doing, certainly part of the foundation work and the sickle cell unit, because we want everybody to be tested to know their hemoglobin status. The second area of focus as it relates to care for sickle cell patients in Jamaica is the health system. And this is provided through the sickle cell unit, the public health system, as well as through private services. And thanks to the MRC and the Sickle Cell Trust, the patients in Jamaica have the privilege of receiving free care through a comprehensive medical facility at the sickle cell unit. And I really want to pause to acknowledge the hard work of the team at the sickle cell unit. So this facility offers a daycare treatment facility similar to an A&E. So you can go and be thoroughly treated. And not just that the physical facility is there, but the warmth and the care of the practitioners who are there. So the patients feel a sense of belonging just going there. And so that's an element that we have that we're thankful for. At the unit also, there are specialist clinics. So once per month, there's the orthopedics and the urologist who visits. We have the service of a social worker, and the lab and diagnostic tests are done. So this is an excellent facility that's available for sickle cell patients. However, it's only available in Kingston. And so patients who live much further will not have immediate access. In fact, yes, there are those who will still bus it and drive it and come to Kingston because they feel comfortable. But certainly, this is an area that we would want extended to other regions. And until earlier this year, the unit held its monthly country clinic in Black River and in Black River, St. Elizabeth, and in Montego Bay. But what I've heard from Professor Knight Madden is that there are designated days in other parishes where clinics are available. In continuing, we have also access in private facilities. So with education, more and more doctors and health practitioners are being trained, and we feel more confident going to the family practitioners for treatment. And in some cases, the private facilities are so set up where there is a daycare treatment, and so it prevents the hospital visitation. Of course, it is for those patients who have health insurance or those who are able to pay. So that facility is also available, which provides care and training for us. The public health system, well, yes, we can access it right across the country, but then it comes with its own fair share of challenges. So you have the pleasant experiences and the horror stories, the long wait, the fact that you're sitting out all night, the doctors telling you they're not giving you the medication for the excruciating pain that you're feeling, and those that are saying that you're a drug addict. So the experience varies, although the facility is there. The third area that I want to look at is the need for support. If at all we are gonna function well, achieve our goals and objectives, there must be support. Support in all areas of our lives. Support at home, primarily, support in the school, support at work. And it was out of the recognition of a need for support that 2 sickle cell patients independently approached Dr. Sargent about starting a sickle cell support group in 1992. We were both university students at the time, and we saw that need because we felt that if there is an identity group where we can share information on coping strategies, or just allowing our fellow warriors, sickle cell warriors, as we often call ourselves, just knowing that somebody is there going through that experience with you. And the stories we were hearing, there are patients who are saying for them sickle cell is worse than AIDS. There are those fathers or families who are saying that is jacket them get because, them fit and strong, so how comes them them child have sickle cell? Or there were those who were saying that stories that we're hearing of persons not furthering their education because they heard that sickle cell is a death sentence. So they're gonna die. So it's no use continuing to study because me soon dead. And so with all of those challenges, we felt that there was a need to heighten public awareness for sickle cell disease so that we can reduce a lot of the myth and misconceptions about the challenges and about us, leading a normal life. And with that, we started the support group in 1992. And with that, we have had, annual Sickle Cell Awareness Week. We've published literature on sickle cell disease, and we meet as a group. We even have a WhatsApp group, and it's interesting, some of the conversations that are had in the group. Where do you get this medication? I'm having this pain. What should I do? What should I eat? And so the need for support we recognize is important, and it has helped with the coping strategy. So the other area, in a minute, is research. And I got some information, and I, of my own, thought, okay, what more needs to be done as it relates to research? Because significant work has been done, and we have advanced to this level, even to have this conference, because of the research work that has been done. And I missed the presentation on the orthopedic presentation, but from the information we got, we felt that there was more work that needed to be done on AVN, on avascular necrosis of the femur. And the other area we thought of is, yes, the research is done, but how much is it communicated to the sickle cell population? How much is it communicated in a layman term so we can understand and we can use the information to help to improve our lives? So with that, and with me getting out of time, this is what I want to share with you. But more so, we recognize the fact that because we have a health challenge, it will not and it should not prevent us from fulfilling our dreams and our goals. And this can only be possible through the love, the support, and the care that is provided by all the stakeholders. Thank you.
Thank you very much, Marit. You spoke about the support, the care, and I'll say one other thing. I really agree that when it comes to the sickle cell unit, everybody know your name. Place of belonging. Okay, so we have heard of the Jamaican perspective, and we're now going to invite Renee S. Dale, and she's from Trinidad and Tobago, Secretary of the Society for Inherited and Severe Blood Disorders of Trinidad and Tobago Limited. Can you make her welcome? Thanks.
Okay, good afternoon, everyone. I'd like to thank Professor Knight Madden for extending the invitation to us and the opportunity to be here. This was a great conference, and I'd like to thank all the presenters for their unwavering search for better outcomes. It's really been comforting. Yes. Yeah. Right. I have sickle cell disease, SS. I'm 34, and I have a BA in graphic design. So by no means do I believe that sickle cell fundamentally diminishes IQ. It depends on the severity of the complications and how well you manage that lessens your potential. Right. Fortunately, I have been blessed so far, and I have not experienced many severe complications of SS so far. I remember the story, my dad always tells it, of when I was diagnosed. So I had symptoms as a baby, and they took me to the doctor, and they had the test done. The lab results confirmed I was SS. My mother was AS, but my dad was AA. So of course that's impossible and brought paternity into question and could have been a disaster. So the test was redone, and it confirmed that he was AS. So we've come a long way from that day. And just to stick in that, the debate was a very good one, but I still firmly believe that the primary care giver should be a hematologist. It has not been my experience that physicians, in the adult setting more so, would collaborate and seek learning in treating with sickle cell disease. So I am the secretary of the Society for Inherited and Severe Blood Disorders, which is a parent-patient support group. Just to give you a little introduction about the organization, it started as a Thalassemia Association in 1983, but based on the advice of the Minister of Health at the time, Dr. Kamaluddin Mohammed, now deceased, he recommended that all inherited blood disorders be incorporated under one umbrella organization for greater numbers and lobbying power with the authorities. So in 1987, it became what it is today. We are a founding member of the Thalassemia International Federation, and we have been a voting member of the World Federation of Hemophilia for over 20 years. We have benefited greatly from being affiliated with these organizations, particularly WFH. We completed recently a twinning program with Brazil, the Hemo Center at the university, the Unicamp, right? Where with Professor Ozello, healthcare professionals such as doctors, nurses, lab techs, physiotherapists who are trained in the management of bleeding disorders. Right? Our technical director and founder is Dr. Waveney Charles, a hematologist. Many of you may know of her. She has been a pioneer in the treatment of inherited blood disorders in Trinidad and Tobago, and my hematologist. So I attribute me being here today in a great part to her. The senior vice president is my father, Mr. Edlin S. Dale. Parent, I am the side of a twin. I forgot to mention that earlier. Both have SS, right? So we try to keep on the board members from representing each blood disorder. So our mission is to enhance the quality of life for persons affected by inherited blood disorders, including patients, parents, and caregivers, through promoting national awareness and providing education, because knowledge is the biggest weapon in fighting these disorders. Right? We have meetings monthly where we provide a forum for members to come together, share their experiences, learn from each other. We have live events like our annual walkathon pictured here. And we found it grows every year, and we found this is a place outside of the hospital setting where people are social events, people could come and build relationships and strengthen bonds. Of course, we listen to our membership, the issues they're having, and try to work with the authorities to resolve these issues. And of course, by attending events like these and others held by our international affiliate organizations to keep abreast with global medical practices. A little bit about Trinidad and Tobago is a twin island state. Forgetting to switch this. Right. The overall population is about 1.3 million, with Tobago having about 60,000 people. Right. The ethnic distribution, Trinidad is a diverse ethnic society, as you may know, with the majority East Indian and African descent, and mixed like myself, and a minority made up of Europeans, Chinese, First Peoples, and Arabs. All right? Tobago is a more homogeneous society, with the majority being people of African descent. All right, so I'll talk a bit about the pediatric clinical experience and then the adult clinical experience. So one of the main treatment centers for sickle cell patients, pediatric sickle cell patients, is the hematology clinic at the Wendy Fitzwilliam Pediatric Hospital at the Eric Williams Medical Sciences Complex in Mount Hope. It also has an adult hospital. This serves the central and northern areas of Trinidad, about roughly a third of the population. Right? The ages, the number of patients with sickle cell disease, there are 322 registered with SS and 119 SC, ranging in age from 6 months to 16 years. Right, we also have a significant number of S beta thal and hemophilia 15. Clinic is held on Thursday every week with follow-up appointments with the sickle cell patients 3 months, 6 months, or annually. The medical team consists of one consultant pediatrician, Dr. Greene, who is also here, one registrar, 3 house officers, and a nurse. Right, so babies are tested at 6 months for sickle cell disease, right, either outside or at the hospital. They refer to the hematology pediatric clinic, and siblings of patients are also tested to pick up whether they also carry the gene, because we don't have screening done as yet nationally. Right, the majority of patients enter the clinic when they present with symptoms. So these are just some ways that they access the clinic. All right, I won't really go through it, you can see there. Dr. Greene and her team are passionate, and they've made some recent great accomplishments. Okay, we know that from Professor Isaac Odame with sick kids, that hydroxyurea can be prescribed up from 9 months. So that has been implemented earlier this year, and in the clinic, and parents are taught to mix the formula, because we only get in Trinidad the 500 milligram capsule of hydroxyurea. So that is broken and mixed in up to 10 mils of water or juice. And so the parents can mix that at home. Of course, they don't store it. It's only what they need at any particular time. All right. Also, Dr. Greene developed a pain protocol for sickle cell patients, and it's been mostly implemented in the 3 pediatric wards and the accident and emergency department. Right. A day unit was recently launched for administering blood transfusions, and a youth group was started, which the SISBD is supporting. The medical team realized that some sickle cell patients, more so than others, were having trouble coping with sickle cell. So they would be depressed, bullied in school, experienced peer pressure. So they wanted to create a forum for the children to not only be counseled, but to help each other, and this will aid with transition to adulthood and build their confidence. Right, now on to the adult clinical experience, which things aren't as rosy. In Trinidad, there are 4 RHAs, similar to in Jamaica, which is under the Ministry of Health, and they manage the different hospitals throughout the island with some level of autonomy. Right, the Northwest, North Central, Eastern, Southwest, and then there's the Tobago RHA in Scarborough Hospital. I attend the Port of Spain Clinic, which is under the Northwest Regional Health Authority, and I will speak to that because the SISPD was instrumental with Dr. Charles in starting that clinic many years ago. So the number of registered patients are approximately 150 with sickle cell. There are 15 with thalassemia and about 40 hemophiliacs. The medical team is bigger than the pediatric. 1 consultant hematologist, currently Dr. Waveney Charles, 1 registrar, 4 house officers, 4 RNs, a nursing assistant, and 2 patient care assistants. Our clinic operates 5 days a week, Monday to Friday. Sickle cell patients attend clinic on Monday and Wednesday, with Tuesday and Thursday being considered treatment days for blood transfusions and so on. So there are facilities available for that, as well as chemotherapy for patients with multiple myeloma, and patients can walk in if they're having a manageable crisis, sickle cell patients that is, and they can get fluids and painkillers and either be sent home or warded if it isn't resolved. So the most common sickle cell complications seen in Trinidad include the pain crisis, of course, acute chest syndrome, ulcers, AVN, strokes, and pulmonary hypertension. So this is how patients first access the clinic. I don't really need to go into that in the interest of time. Emergency cases, of course, adult patients go through the accident emergency, and the receiving teams would refer them to the hematology department. Of course, that is a very delayed and unpleasant experience. For most adult sickle cell patients, going to hospital for treatment is the absolute last resort. They would try to treat at home with fluids, painkillers, oxygen, heating pads, whatever, before going to the hospital. And that, of course, is not ideal because it prolongs the crisis and the pain should be dealt with as soon as possible. So some overall comments. Despite the challenges, the Ministry of Health is very supportive. They provide the medication needed for inherited blood disorders, hydroxyurea, X-Jade, factor, fever. They purchase it and it's available for free to the patients. That is not the case for many islands in the Caribbean. So we're fortunate in that regard. Hydroxyurea, I have been on it since probably the age of 17. After having to be hospitalized for severe pain crisis about 3 to 4 times each year. And then I got a couple acute chest syndrome. So Dr. Charles recommended that I start hydroxyurea. And after the 2nd year or so, I have not had a pain crisis. So that's looking at over 15 years pain-free. Yeah? So that has really changed my life because I've been able to do more things that I wouldn't have even considered doing before. There's still an issue, however, of skepticism by some doctors and compliance with patients in taking it, because I would speak to them and they would say they'd start it and then they would stop. The thing is, in Trinidad, there are different brands available. Of course, there's the one from Canada, you'll probably know which brand I mean, that is widely acceptable, but we don't get that as often. It costs, some may choose to buy it outside, and it costs about $360, about 52 US per bottle of 100 capsules. But more often than not, you'll get the generic brand in the hospital, and the patients would think they're not feeling as good taking that, right? But we try to tell them that it's better than not taking hydroxyurea at all. And of course, we know about the stigma of narcotic addiction. Some doctors and nurses, when they are warded, still tell them you're faking the pain to get a morphine or pethidine fix, right? So I think that it's important for a study to be done in how many sickle cell patients are actually addicted to narcotics, how to determine if they are addicted, and prevention and treatment of addiction. So that leads me to research. I'll try to breeze through this. Trinidad does not do much sickle cell research. There's some done in the UWI, St. Augustine, but nothing on the scale of Jamaica. So I will talk about the newborn screening in Tobago, right? That the initial proposal was done by Dr. Althea Jones-LeCointe, who was a consultant hematologist attached to UWI at that time and was trying to start newborn screening. And Dr. Charles in Tobago had a history of over 20 years of assisting pediatricians with managing sickle cell disease. So they developed the proposal with the support of the SISBD, INSERM in Guadeloupe, and CUREST. I apologize for that omission. And the Tobago Regional Health Authority ran with it. And it was initially a one-year study, and it was continued up to this day, as we know. Right? It's a heel prick test. Samples are sent to Guadeloupe for analysis once per month. The results are emailed. For those that are diagnosed, results emailed within 2 to 3 weeks. And after diagnosis, the patients and the family is called in for management and counseling and so on. Right? Scarborough's hospital is the only hospital on the island. As I said, Tobago's population is more homogeneous. Right? So these are the results published this year in the International Journal of Neonatal Screening from 2008 as it started to 2017. Sorry. Right. So I won't go through it in detail, but you see the sickle cell prevalence is 1 in 176 births. Dr. Gillian Wheeler, who's a pediatrician and allergist who was closely involved with the screening, reported on results up to 2015 that almost 50% of the parents of the children diagnosed were not aware that they carried the sickle gene. Right, so the medical management after diagnosis is, of course, prophylactic penicillin, folic acid, hydroxyurea, vaccines. Right? Dr. Keishi, who is also another pediatrician closely working on that project, in preparing this, she told me that they have seen significant results where there's a reduction of the number of children being hospitalized for sickle cell related complications. They come in, they're being hospitalized for other stuff like asthma and pneumonia. This is data she's now starting to collect. But it's attributed, of course, to the newborn screening and the early management. So, research from a patient perspective, I asked several other sickle cell members what they hope to see in the future in terms of medical research. Of course, the main answer is a cure. From this conference, I'm seeing a lot of hope, and it is looking that the most viable options are gene therapy and the bone marrow haploidentical transplant. So the hope will be for that to be perfected and be more viable for a larger number of people, especially in our region. Better pain management in terms of implementation nationally of a recognized protocol, including safe alternatives to morphine, since there are several patients who say morphine does not work for them. Leg ulcers. This is without a doubt my biggest fear as a sickle cell patient. Despite every other complication I've heard of mentioned today, it still remains the one that triggers an emotional response. Right. I've seen how people suffer. Fortunately, I haven't had any as yet. Not as yet, but I haven't had any. And yeah, I won't, hopefully. Yeah, so I've seen how they suffer and how long it takes to heal. So I sincerely appreciate the work that Dr. Miniti is doing, and I'd love to share her protocol for treatment back home. Earlier detection methods of vascular necrosis, I think that's important. I was comforted by the work that Dr. Banks is doing, but still, like, for the last few months, I've been getting a slight pain in my shoulder when I move it. So, of course, I'm afraid that it may be AVN, but I did an X-ray, nothing was shown. So I was disappointed to realize that it seems that I have to wait until I get excruciating pain before something can be done. But of course, this fear probably also has to do with surgery. But as I said, Dr. Banks has convinced me that surgery is the best option. So we'll see. I don't know if this is possible, but there are cases of sickle cell patients, parents of children who need transfusions, but they refuse it due to religion or as well the fear of contracting a blood-borne disease. So I don't know if there can be alternatives to blood, but that's a hope. And in the interest of time, thank you. That's the last slide. Thank you very much.
Okay, thank you very much, Renee. And finally, we're going to invite Mr. Howard Woolley, who's going to give the perspective from his own experience with his wife in the U.S. Thank you.
Well, thank you all. I've been here for the last 2 days, and I've heard a lot of things that help me put in perspective my wife, Gail Campbell's life. She was fortunate to live to be 58 years old, and 2 years before she passed, part of her career, she was a journalist, so she wrote her memoir, and I was able to get it published a couple of years after she passed. And if she was here, she'd say, "Hold up the book." So there it is. To avoid any controversy, during my 34 years with Gail, I saw her treated by an excellent primary care doctor and an excellent hematologist. Okay, so are we done with that? So I promised the organizers I would tell some of Gail's story in the context of the things that you're talking about. And I know I'm standing between either you and the airport or you and the Pegasus bar, so I will keep this tight. She was, excuse me. She was born in 1957, and in 1964 was diagnosed with SS, sickle cell anemia. It was discovered quite by accident. Her mother was going for a government job in the Washington, D.C. area and had to take a blood test, and then they discovered that she had, I believe, SC, and the father also had the trait, and Gail and her middle brother ended up with the disease. Just a little bit about Gail. She had a laugh that would fill this room. She didn't know the word procrastination. She was a high achiever, intellectually curious. She did a lot of things that sicklers are not supposed to do. She loved aquatics. She snorkeled the Great Barrier Reef. She snorkeled up here in the Grill back in 1986. And she traveled to 6 of the 7 continents. She was a real go-getter. I met her at Syracuse University, and I was listening to the psychologist talk, and Gail's first year at Syracuse University, she had a sickle cell crisis just before finals. So she missed all of her finals. Her parents had to pack her up. They went back to Washington, D.C. She was hugely depressed and everything, and she actually did see a psychiatrist. But she came back, and she was a good student at Syracuse University. I met her there, and actually after a few dates, she had a sickle cell crisis, and she didn't want me to come into Upstate Medical Center and see her in crises. And I told her I was going to be there with her, and it started off a love affair that went on for 34 years. Gail was very precise, so we got married on Valentine's Day because she wanted to be sure that I would never forget it. Never forget that. In the orthopedics area, Gail had several hip replacements. Her first one, she was 28 years old, and her last two, she was in her 40s, late 40s, and at that point, things had become so complicated. They actually had to be done at the Mayo Clinic, and they were done successfully. She, in terms of dealing with healthcare professionals who didn't really understand sickle cell, Gail was her best advocate. Gail was very direct. We had a movie back in the 90s, A Few Good Men, and the famous line, you can't handle the truth. Gail didn't know how to tell you anything other than the truth, and she could speak up for herself. But when she couldn't, when she was in extreme pain, I was her advocate. And I was just thinking the other day that when she was really, really in pain, and she would send me back out to the nurse's station to see if the hospital would send someone in, I developed a technique. I was always polite, I was always firm, I was all those different things. But at that point, I would just go out to the nurse's station, and I'd say to no one in particular, but to everyone, including the other patient advocates that were around, my wife is back in that room screaming her head off, and I want to know who in this hospital is responsible for taking care of that. And sometimes that would get some action. I spent more time in the offices of administrators at hospitals outside of our area looking for help. And I will have to say that when we were outside of our area, and we traveled a lot, we did feel better when the ER people would finally bring in the hematologist. Yes, because it seemed like the folks in the ER just didn't understand it. And when you have that lack of communication coupled with extreme pain, it just doesn't, it just doesn't work. The couple other highlights. So yesterday you had a speaker who said that hydroxyurea in the United States became kind of the protocol around 1992. Gail was very fortunate that we had a proactive primary care in Columbia, Maryland, which is equidistant between Washington, D.C. and Baltimore, where Johns Hopkins is. And he was aware of the work that Hopkins was doing on hydroxyurea. So Gail started taking hydroxyurea in 1987. And what used to be 5 and 6 times a year going into the ER, excruciating pain, we went through a period of about 7 years where there was no hospitalization level crises. And some of the other byproducts is, since you like to snorkel and all that kind of stuff, those kind of many crises didn't happen anymore. And whereas we had to be careful about going to places like Denver, 7,000 feet, or Johannesburg, 7,000 plus feet. When we went to South Africa in 2006 and we landed, she had no issues. And this was all because of hydroxyurea just changed everything for us. Toward the end of her life, some things really, some real complications came in. 2011, a ankle fusion surgery, got infected, and she ultimately had to have that ankle amputated. And that's where the whole self-esteem thing came in. But that's also where it's important for the person who loves this person to make sure that they know that you believe that they're still the same person you met when you started. It can't be, you're sick, you lost an ankle and you're different. You're the same person I loved at Syracuse University, and that's just the way it is. And so and the other thing about her, she had this strong personality. So we're sitting in the office of the prosthetic provider, and Gail says, "I want to swim again. I want to swim again. I want to swim leg. I want to swim leg." And he's not getting it. He says, "I can't get you to swim leg. I don't know where to." So Gail had studied French all through college and was fluent, and she loved to travel to France and everything. And I found a French company called Aqualeg that made prosthetics for swimming. And Gail put the cell phone in this guy's face and said, "I'll call this guy now." And it took a while, but Gail and the CEO of Aqualeg eventually connected, and Gail was back swimming again with her, her Aqualeg. But unfortunately, after that, about 6 months after that, she did get pulmonary hypertension, and that was problematic. But again, in typical Gail style, she took up a form of scuba diving called Zuba, where you can put the tank on the side of the pool with a 30-foot cord and keep going. I showed her pulmonary care expert a video of her swimming like that, and he was like, he was very kind of low-key kind of guy, and I could see he was sort of like, "That's my girl," that's Gail. So we were fortunate to live a great life together, and she wanted to tell the sickle cell story from the standpoint of a journalist. And so the last 2 years of her life, she wrote it all out. And some of the people that you all know, like Sophie Landskrin and Rob Brodsky at Johns Hopkins, they've read her book, and James Taylor over at Howard University, formerly of NIH, and they've gotten a lot out of it. And I'm not here to sell the book, although the publicist would say, "Howard, you're there to sell the book." Sickle cell had such an impact on our life, and Gail only asked me to get the book published. She didn't really ask me to do too much more, but she had started some philanthropy around sickle cell retinopathy at Johns Hopkins, and so I kept that going, and I appreciate my friend Rosalind mentioning the Gail Campbell Woolley Project Echo that the family's involved in. And with that, I thank you very much.
Wow. I mean, when we said we were going to have a patient panel, I knew it would add, but I had no idea. Can we give them all another round of applause? The thing is that no matter how much empathy we have and how much we care about people who have sickle cell disease, when you actually live the experience, it's just a whole different level. So you have an opportunity now to speak to 3 very articulate people who have been a part of that experience. So we do have a few minutes for discussion if there's anybody who wants to make a comment or ask a question.
I have to say that I actually feel very privileged in looking after people who cope with this, disease, to see how much they can actually bear and put up with it. And I get a lot of strength. So that things that I feel sometimes, I thought, what are you complaining about, So that whatever pain or whatever I have, I will put into perspective. Because when I see how much the patients with sickle cell put up with, I just kind of feel that whatever I have is nothing.
First of all, thank you so much for sharing your stories, for your openness, and for sharing the amazing things that you've all done. I really think it kind of lights a fire under all of us just to think there's so much that needs to be done, and yet if you're passionate, you can clearly accomplish so much. And I wanted to comment a little bit on something that Ms. Wright said about how we really need to be getting back what we do in research to our patients. And that's something that my patients at my clinic have been telling me a lot. They're saying, we're happy to participate, we want to help you, we want to learn more things. But if we're going to do that, you better tell us what you learned. You better get back to us. We need to be involved in this. And so something that we've started doing at my center is that every time we publish a manuscript, we make a handout to accompany that manuscript. It's kind of like a postcard that you get in your mail and throw away. And on the back, it thanks the patients for participating. But on the front, it has sort of a visual abstract, but at a patient level. So it really says from that manuscript, what was the thing that we learned? Why is it important? And we hand those out at our clinic. And it's really been very popular with the patients. So I guess this is sort of a commercial break, but if anyone is interested, I'm happy to share sort of how we developed that, how we do it, and I would also love to take advice on how to improve it.
Wonderful. Thank you very much. Poonam? David?
So I would like to echo what you just said. Bravo. Really great. This is the kind of spirit that drives us to do more research. But addressing the part about informing the patients, we at Cincinnati have a sickle cell research and education day dedicated just for this. And maybe if other institutions who want to adopt this is one of the most popular events we have. We usually time it around the end of August, which is back to school time. And we get a lot of companies like Nike and many other Office Depot and all these to provide back to school supplies for free for the kids. So that's, an attractive option that brings all the families with their other siblings, the patients and siblings. It's a very nice bonding event because we have the entire family and extended families there. And the day is about a 6-hour event. We have every half an hour, we have games, and then for 10 minutes, a physician actually tells what has been achieved and and in the background there's slides playing, continuously about how to care about your child with sickle cell disease. And that's actually a very popular event. We also we identify through our database patients who are eligible for different research trials, and ahead of time, we have color-coded trials, so they get a postcard which says which trials they are eligible for, checked on there. So when they come, they're color-coded booths, and they don't have to stand in line at the wrong place to find out. They can just go to the booth, whichever color they got, and they can, if they want to participate in research, they have an opportunity to do that. And the patients, the feedback we get is really very, very good. And that's the forum we use. But I think what you suggested about having a lay abstract be distributed in the clinics is an excellent idea. We're going to use that too.
So I also wanted to just make a comment and echo everything that everyone said. This has been really terrific and inspiring, and this is a kind of shot in the arm that we all need to drive us back to do the work that we do to try to make things better for patients living with this really awful disease. But I want to make one point, reiterate one point that Deepika made earlier, and that is something that plagues the life of sickle cell patients, and that is going to the ER and being treated like a drug addict. So we have data that proves that that's not the case, and I just want to share that with you one more time. When we do a bone marrow transplant, and that bone marrow transplant is successful, and the pain goes away, they don't come back anymore to the hospital for drugs because they don't need it anymore. The way you get rid of the need for pain medications is to get rid of the pain. And when you do that, that need for pain medication goes away. So I just want to empower you with that knowledge so that you can share it with others who are suffering the indignity of being, called a drug addict when you go to the ER.
Thank you very much for sharing your stories. If there is a possibility, it would really be an honor for you to come to some of the fora or the meetings that we have in the different countries in Africa to share and to inspire your stories. We're just starting to build up the patient community and really learning from your experiences and learning to see how they can communicate that information would really be very, very powerful. One of the things at my level or with my experience that I've had is the question as to why am I impatient? What's the hurry? Why do I want things to happen very quickly? And really for me, my personal experience is mainly because with every day that we don't get to identify the people who have sickle cell disease, when we don't get a chance to provide them with care, we have patients dying. I had 3 out of 5 of my cousins who were born with sickle cell disease, and by the time I started working in sickle cell disease, 2 of them had already died, and 1 subsequently died, after 5 years when I had started working on this. And so every day, as Swile says, when you get frustrated, when you get tired, the one thing that makes a big difference is just sitting in the clinic and listening to stories or listening to the experience and knowing that you're making a difference, even if it's in the smallest way. That really, really helps. And I'd really like to ask you not to give up sharing your stories, not to give up inspiring people, and encouraging us to continue working in sickle cell disease. Thank you.
Okay, I'm not seeing any more hands, so I'd like to thank the 3 of you very much. I think this was the perfect way to close our conference because it really gives us the impetus to keep going and to know that what we're doing makes a difference. Thank you very much again. And with that, relatively on time. I want you to understand that we live in the country called Jamaica. We have Jamaica time. So for us to even be close to being on time is quite remarkable. But I think this has been a wonderful conference. I thank each of you for being here. And we know that we literally hand over the baton for next year. It's going back to the NIH, so I'm going to give the microphone to Swile for her to say the last words.
All I want to say is we'll probably be having it around October as well, but I can't tell you the exact dates because we've got to go back and choose the availability of the lecture. But we'll let you know as soon as we can find a date. And of course, we need all the figures and the metrics to confirm, to persuade our directors that we need to continue with the funding. And I echo what Jennifer said. Thank you all so very much for making, this so successful. And of course, we thank the patients who contributed to the panel.
All right. Okay, so as we close, I'd like to thank all of those who really put in all the hard work with all the logistics and so on. So I thank the team from the sickle cell unit, particularly Cassandra, and also the team from the NIH, who also worked very hard to make this a reality. And for all of you who are staying over in Jamaica, have a good time. And for everybody, safe travels. Thank you.